Hey everyone, welcome back to Long Haul. I'm joined by Dr. Bruce Mast today. He is the Chief of Plastic and Reconstructive Surgery at the University of Florida College of Medicine. He completed his MD at Robert Johnson Medical School in New Jersey, general surgery residency at Medical College of Virginia in Richmond, and his plastic surgery fellowship at the University of Pittsburgh in Pittsburgh, Pennsylvania. My best friend actually just got into Pitt Med, so I visited him this past September. So I really like Pittsburgh, actually. It's great up there.
Yeah, cool.
First question, keeping up with COVID, what advice do you have about the booster? If someone has both doses, would you recommend getting the booster and the urgency of getting the booster?
Yeah, so I absolutely recommend getting the booster as soon as you're eligible for it. The data is really convincing that your immune response in terms of antigens are significantly elevated with the booster and provide the maximum protection against Omicron or other variants that exist now. You know, even though there are people that have been boosted that are getting Omicron, they're really having cold symptoms. I mean, really mild URI symptoms, maybe a little fever, maybe a little cough, and it's over and done within a couple of days. So it really is effective. The vast majority of people that are being hospitalized are non-vaccinated. The ones that are vaccinated are those that have multiple medical problems or comorbidities, such as immunosuppression from transplantation. And the folks in the ICU are those that are mostly unvaccinated.
Okay. Do you think this will be more of like an annual booster thing, like we do with the flu? That we'll be getting a COVID booster every year?
Yeah, so this is mostly speaking out of my personal opinion rather than my expertise, since this stuff is really related to plastic surgery per se. But I think it's gonna eventually evolve into something like the flu.
Okay.
Where it's going to be a virus that exists that will be a problem seasonally or throughout the year that will have to get booster shots every year, or maybe even twice a year. I don't know, but I can't imagine. It's not. I think most of the pundits think it's not going away ever at this point. And then each significant strain has evolved into one that's less lethal. So Delta was less lethal than the original variant. Some people think that was related to the fact that our treatment was better, which it was, because we knew how to treat the disease, but it was probably also a less virulent strain. And Omicron is significantly less virulent. And some folks have postulated that that's sort of the evolutionary process. Evolve to survive. So if a virus evolves as a novel virus and its first iteration is to kill its host, it will die also. So
right.
It becomes less and less virulent or less and less deadly, it'll have a greater chance of survival. So that's sort of my opinion.
Makes sense. Getting into more of your expertise, if you could tell us a little bit about what is plastic surgery as a specialty.
Plastic surgery is a specialty that treats all age groups and all aspects of the body. It comes from the word plastikos, which is Greek, which means to mold or change. So we're sort of in the business of taking parts of the body or other parts of some elsewhere, or even artificial materials, and use them to restore, reconstruct, make, or refine aspects of a person's physical being that have been altered by either time, such as aging, congenital maldevelopment, trauma, or disease. So it's a pretty broad field. It combines mostly reconstructive surgery with an element of aesthetic surgery, although most of the public thinks mostly about aesthetic surgery and cosmetic surgery when they think about plastic surgery.
Mm-hmm. You mentioned a little bit about the subspecialties. If you could tell us a little bit of the different subspecialties that are in plastics.
Right. So you can have a broad basis practice in plastic surgery and have that as your practice, but there are subspecialties. Plastic surgery leads to subspecialties in hand and upper extremity surgery, which most people, until you're in the know, don't really think we do that. But it includes fractures. It's not just the soft tissue and nerve work, but the hand and upper extremity, similar to orthopedics. There is microsurgery, which is mostly it's reconstructing where you auto transplant to yourself. So you take a part of the body with its arteries and veins, and then you bring it to the part of the body where something is missing, and you use that tissue to reconstruct that part by sewing the blood vessels together. That's considered to be microsurgery because the vessels are very small. Craniofacial surgery, mostly pediatric craniofacial, but adult craniofacial, that's to treat in the pediatric population things such as cleft lip and palate, but also craniosynostosis and other congenital abnormalities of the skull. And craniosynostosis is when the suture lines in the baby's head fuse early and their heads get really messed up in shape. And then sometimes it affects their intracranial pressure and can have effects on development and cognition. So those are basically those really cool operations where you basically, with a neurosurgeon, take off the skull, reshape the skull, and move the entire rim around your eyebrows out and all that stuff. It's really cool stuff. Mm-hmm. And that's craniofacial surgery, but it also involves adult craniofacial surgery. There's aesthetic surgery, and there are fellowships that are done, and you can specialize in aesthetic surgery, or you can do aesthetic surgery as just part of your regular practice. Let's see, what am I missing? There's aesthetic, hand, micro, and craniofacial. Those are the four big ones.
Okay, gotcha. And the years of training to become a plastic surgeon?
There are two routes to train as a plastic surgeon. One is what's called the independent program, which is like the conventional, like a fellowship. So you do a general surgery residency at a medical school, and then it's a 3-year additional training program for plastic surgery. And then if an additional fellowship year may or may not be required to do the other things like hand fellowship or micro, that type of stuff. And then there's the integrated program, which is you match into a plastic surgical training program right out of medical school, and that's a 6-year residency plus or minus the fellowships. So the training is either 6 years plus 1 or 2 for fellowship if you go right out of medical school. If you do a general surgery training residency first, then it is 5 years of general surgery and 3 years of plastic surgery. So that's 8 years altogether. And then maybe another year of fellowship training. So it could be up to 9 years of training.
Gotcha. When did you know you wanted to do plastics? Was it through your rotations in med school? Did you always have an idea that you liked plastics when you went into med?
No, I had no idea I wanted to do plastic surgery until I was a general surgery resident. So I went to my general surgery residency thinking I wanted to be a pediatric surgeon. Okay. I was really kind of enamored with the congenital defects and the surgery be a part of that. I really like general surgery. But then I did 2 years of research during my general surgery residency, took 2 years off. And the research I did was in fetal wound healing. And we worked very closely with the plastic surgical laboratory. And so I ended up getting exposed to plastic surgery. I ended up presenting a lot of the research at plastic surgery meetings because it was wound healing. And I got to find out what plastic surgery was all about. And that's how I ended up getting interested in it.
Awesome. Most rewarding part of your job?
We're the good guys. Globally. I mean, someone comes in and you go, you had breast cancer, got to remove your breast. Here I am, I'm going to put it back together for you. Right? You put your face through the windshield and smashed in 100 pieces. Here we are to put it together for you. You broke your leg and you have bones sticking out of your leg and a big piece of meat missing too. We're going to work with orthopedics and put your leg back together and save your leg. So we're sort of the good guys as opposed to other things we're taking parts away but so it's been really rewarding like that. I think the big reward is plastic surgery is a lot of times about body image and self-esteem. Right? So can someone live without one breast? Of course they can. Can they live with a large nose? Of course they can. But sometimes we do these things and to either whether it's reconstructive or aesthetic, and people come back and you can just see the difference in how they present themselves to you and the public, because it really affects their self-esteem and how they think about themselves. And that's what's a rewarding part.
Absolutely. And the mental health aspect of it, as you mentioned, is definitely very rewarding. With that same token, the most challenging part of your job?
The most challenging part of the job is dealing with that, because it's, everything we do is visible. And so if you have your gallbladder removed and you still have, no one knows whether or not it looks nice in there, right? So all you know is your gallbladder pain's gone. So everything we do is very visible. So sometimes it's a challenge dealing with some patients that don't have reasonable expectations of what can be done, and sometimes it's just a challenge to have people understand the limitations of what we can do.
Okay, gotcha. One thing I wanted to ask you was your lifestyle. I know it varies between physicians, but typically as a plastic surgeon, what hours would you work, and are you on call on the weekends?
All right, so pretty much almost all all medical specialties require call to some degree. The nice thing about plastic surgery is that we're mostly a scheduled surgical practice, so most of our stuff is non-emergencies. Now, so the only caveat to that is if you do hand and upper extremity surgery, there's a lot of hand trauma that you have to deal with. But even then, a lot of the stuff can be saved to the morning. It doesn't necessarily need to be done in the middle of the night, unless it's something really bad, devascularization or some bad infection or something like that. So most plastic surgeons for surgical practices have a very nice lifestyle because it's controlled in terms of scheduling. My personal lifestyle is, I operate about half my clinical duties are about 50 to 60% of my time, and I have administrative time elsewhere. And I've developed mostly a cosmetic and breast reconstruction practice, which is a very scheduled. So I have my days start between 7 and 8, and then between 5 and 6, and then I frequently have Zoom meetings in the evening for the various national or regional organizations I have leadership roles in. And then if you do some of the reconstruction stuff can go late because you sometimes have to wait for, let's say, a big tumor or cancer to be removed, and you have to go in and fix it afterwards. So even if you do that a lot, there's usually maybe 1 day a week where you may be working a little later, but you can alter your day and work it out that way.
Okay. How competitive is it to match into plastics?
And plastic surgery is the most competitive match. Out of medical school, it's not that much more competitive than orthopedics or dermatology, but it's still a rank side. But nevertheless, I think the latest numbers are in the 70 to maybe low 80% of applicants are matching into it. It used to be as low as 50%, but it's changed now because there are more positions available coming out of medical school, and then I think we do a better job as educators to steer students away who are not competitive, so they don't waste their time. So the pool is very competitive, and the key to getting in is academic success. So if you don't academically do well, then you will not get in. It doesn't matter. Maybe it doesn't matter how many research papers you could. Well, I guess someone who did academically okay and has like 5 New England Journal of Medicine articles may get in somewhere. But the research is very important too. But really, the academic part and the literature reference the most important. So I tell all medical students that they, even though like a UF, the first 2 years are pass fail, they should treat it like it's still A, B's, and C's, because the more they get out of it in the first year and second year, the more they'll be able to do well in the third year, which is a clinical year, because they have that basis of knowledge they got from just trying to get A's to begin with. And so it works out well that way.
Right. What is the typical compensation for a plastic surgeon?
Well, typical, it varies. I think, I think most, I could tell you academic centers are starting new people out of practice in the 350 range to higher. And then, the national charts show the upper percentiles for private sector, probably in the 700,000 or 800,000, I think. But there's a pretty broad range. It all depends upon the type of practice you have and what you do. But I think the 350 to 550 range is probably the average span for most people.
Oh. So this next question probably doesn't apply to you. I'm going to ask you anyways. If you had the option to go back in time to change your specialty, would you?
No, I don't think I would.
Are you satisfied?
I think, it's been really good. It's been a good ride.
Mm-hmm.
It's It's been a really good practice. I've done a lot of different things. I did academic practice for 5 years. I did private practice for almost 11 years, and I came back to academic practice. I got to do really nice surgery, treat good people. I work in a really good environment. Training the residents and working the medical students is a lot of fun, and it's really rewarding. Contribute on a national stage, so it's all good. I mean, I don't think I would have been if I had to do it again. This is probably what I would have done. The reality is that, the big thing is people really fret about the specialty that they're going to do, but the reality is if you find there's more than one thing that could be interest to you. I would have been happy being an interventional cardiologist, and I probably could have been very happy. I would have been happy as a general surgeon. I would have been happy even as an ER doctor if I had to. Mm-hmm. But those weren't the top choices.
Right.
And I think if you go into medicine for the right reasons, there's many paths out there, and people shouldn't get caught up in the singular path that they think could work for them.
Right. Last question for you, Doc. A common misconception about plastic surgery.
Mm-hmm. I'm sorry, say that again?
A common misconception about plastic surgery.
A common misperception about plastic surgery is that it's all aesthetic and cosmetic surgery. It really isn't. I think if you look at the American Society of Plastic Surgery membership, which has covers about 90-95% of all board certified plastic surgeons in the U.S., the vast majority of them have a reconstructive aspect to their practice, and there's only about 10% that are completely cosmetic surgeons. So most of us still really do reconstructive surgery, whether it be a skin cancer reconstruction, breast reduction surgery, breast reconstruction, craniofacial, all those other things I said. So it's not just cosmetic surgery.
Right. So Dr. Mast, thank you so much for taking the time and speaking with us and telling us more about your specialty. Really appreciate it.
My pleasure.